see a lot of families who come in and they're like, we've stopped bubble baths. We only do showers. We've changed our laundry detergent. We use unscented things. And I think all of those are great. I also am a believer, especially as a parent, like kids like baths. I don't love bubble baths, but I tell families, like, if your kid wants to take a bath, like, I'm okay with that. I don't think that that's the reason that they're having a UTI.
What if one of the most common diagnoses we make is also one of the most nuanced to get right? Pediatric urinary tract infections, or UTIs, don't always follow a script. They can be subtle, inconsistent, and easy to over or under diagnose. Aside from clear urinary symptoms, they can show up as fever without a source, vague abdominal pain, new incontinence, or a child who simply is not acting like themselves. And in those moments, the decisions we make, such as who to test, how to collect a sample, and how to interpret results, carry real clinical weight. This is Charting Pediatrics. To dive into this bread and butter topic, we are joined today by Kevin Olson and Meghan Rommel. Kevin is a physician assistant and Meghan is a nurse practitioner within our Pediatric Urology department here at Children's Hospital of Colorado. Kevin and Meghan, welcome to the podcast.
Thank you so much.
Thank you for having us.
So, I think this is it's a common thing in pediatrics, urinary tract infections. So it's a really important topic, but it's nuanced. And I was thinking maybe we would sort of focus on the infants first, because I think there's a lot of interesting discussion early in life, and then we can kind of expand by age.
Sure.
Absolutely.
So why don't we talk about sort of presentation of urinary tract infection first, and then we can kind of get into workup. How does it usually present in the first year of life?
It really varies. Well, the first 12 weeks of life, we have to be cautious because sometimes we have hematogenous spread of bacteria to the urinary tract for infants. So often a different presentation, and it could be fussiness, it could be just general poor feeding and such. And as kids get older, then we have different presentations. It can be in teenagers, it may be lower urinary tract symptoms. In children, it might just be GI symptoms. It's very vague and very varied, as you point out. So we have to have our antennas up and look for all of those cues.
I think one of the big things that you're looking for in an infant is an unexplained fever. And I tell my families, it's a high fever. It's not just like, oh, you feel kind of warm. It's like, I pick you up and, oh my gosh, you are hot. Something is wrong. Like, you're going to take them in. You're going to go see your pediatrician. After hours, you're going to the ER. Like, we're going to work up for that high fever that you're just like, I don't know, something's wrong. And it's typically a high fever that's unexplained, meaning like that they don't have a cold, cough, the viral junk that's going around. And you're wondering, like, what's happening? Like, why is my kiddo so sick? And that's typically kind of our tipping point where we're like, we should get a urine sample, and we need to get that urine sample with a catheter so that we know that we're getting a really clean sample from the bladder instead of the bag that collects all the lovely skin bacteria plus then some urine bacteria. And you're kind of wondering, is this true? Is this not? Like, what am I doing? And when they're really little, it's hard as a parent to have a sick kiddo, and you want to make sure that you're treating the right thing for them.
A couple of things I want to call out, which you guys touched on, was that, source of fever. So when you don't know what the fever is coming from, it may be warranted to check the urine. I also want to say that kids are so often with viral infections, it doesn't necessarily rule out a urinary tract infection. Correct?
Yes.
Yeah. So, I know there are a lot of algorithms that exist out there based on sort of age and some other characteristics, whether or not to test, and those are easily accessible. Can you guys touch on a little bit sort of the gender differences, especially as it pertains to age?
Yeah.
Because I think one misunderstanding is who it's more common in, boys or girls, early in life in the first couple months.
Well, I mean, the incidence in really UTIs occur more in the first 2 years of life. The first 3 to 6 months, boys about 4 times that of girls, and about 10 times that of girls if they are uncircumcised. So after that, there's kind of it flips over. It's usually girls quite a bit more than boys.
And is it only because of the circumcision question, or are there other anatomic variations that may increase the likelihood for a boy to have a UTI?
Well, basically, UTIs are ascending infections. So the majority result from bacterial colonization of the urethra. But that by itself wouldn't cause infection. It's usually a mismatch between the bacterial virulence and the host defenses. So of modifiable risk factors for hosts, if somebody is circumcised, that makes a difference. Breastfeeding, believe it or not, makes a difference. And bladder bowel dysfunction, which we'll, I'm sure, circle back to later. There are a lot of non-modifiable risk factors, which is age, prematurity, sex, even genetics. There's a CXCR1 gene, neurogenic bladder. There are things that we cannot modify, but there are things that we can modify. So that's important to keep in mind.
One of the discussions we have often in primary care is whether or not to do a circumcision. And, this data that you just mentioned is pretty profound,
right? But
it's not to the point where the American Academy of Pediatrics necessarily recommends a circumcision for medical reasons.
Well, there was a study that showed you would need, the number needed to treat was about 114 circumcisions to prevent just the average boy to get a urine infection. It would be 4 if they had recurrent infections. I'm sorry, it would be 11 if they had recurrent infections, and you'd have to only do about 4 if the child has vascular reflux to prevent future infections. So it really depends on the situation, basically. But circumcision is a whole topic in and of itself that we can circle back to or address at another time. But
probably another time. Yeah.
I think one of the things to know is that we don't always start out with offering a circumcision for our males that have a febrile urinary tract infection. We're testing for VUR or vesicoureteral reflux to help rule some of that out. And then we're also looking at the foreskin, and we can treat with steroid creams to help open up the foreskin a little bit and allow the urine to pass more easily instead of that trapping mechanism, which is kind of the thought behind some of the increased risk for a UTI on an uncircumcised male. But our first line isn't like, hey, you have to go to the OR and have a circumcision because you've had a UTI as a male and you're uncircumcised. Like, we can try and manage it conservatively from that standpoint. And I mean, I see plenty of patients who are uncircumcised that did not have urinary tract infections, and then those who were circumcised and did have a UTI. So it's definitely not a hard and fast rule.
Right. And of K-cut anomalies, really posterior urethral valves are the only K-cut problem that we see that there is a really shown benefit of doing circumcisions. That's one of the few that we would recommend, but absolutely.
Yeah. This gets into your expertise, which, sometimes is a referral is necessary. But Meghan, you were speaking a little bit about initial testing, and you talked about the bag, and someone urinates, and basically, for those who don't know what we're talking about, basically you put a bag, you clean the area as much as possible, for girls and boys around the urethra and around the sort of surrounding area, but then put a bag to try to collect some urine. And what you're trying to prevent is to do a straight cath, right? Mm-hmm. Because straight caths are painful. Mm-hmm. But, you touched on that we can get false positives.
We can. And I think that if you're dealing with an infant population, it's really important that we figure out, do they have a true UTI or do they not? And the way that we determine that is with a straight cath, which is the gold standard for a urine sample, that it needs to be a single organism and grow greater than 100,000 in the colony forming units. When you collect that bag specimen, you're really not sure. Are you getting some Enterococcus facilis and some E. coli that there might be some microscopic stool that was left on the skin, even though you tried to clean it before you put that bag on? Right. And then you're kind of dealing with this mixed picture, and it's like, well, do we need to do antibiotics? Like, what's the cost benefit of treating that baby with antibiotics versus do we give them a catheter? And so I tell families, I'm not as concerned with older kids when they start to get a little bit older. You can try and get a voided specimen on them. I really dislike seeing bag specimens, especially when they end up in my clinic and they've had 5 or 6 UTIs is what they're being sent to me for. And there's either no culture that's done or they've all been collected with a bag specimen. Because I think the first 1 or 2, if you collect them with a bag specimen and it comes back positive, and then they're coming back to see you a second time, probably at that time we should collect with a catheter so that we know for certain like what we're treating and what's happening.
Absolutely.
I'm very big on doing as little invasive testing as possible. And I don't like putting patients on medications unless they really need them. But we have to make sure that we're also being diligent in treating them when they need it.
And a bag is really only useful if it's negative.
That's right.
Yeah.
Yes.
88% are false positive. So yeah.
Yeah, that's the discussion I usually have with my patients, is to say, I can do a bag. It's not going to hurt your child. And if it's negative, great. We got great news. If it's positive, now I really have to do a cath, right? You want to make sure you get the right diagnosis.
And I think that's totally fair. I tell a lot of my families that, like, if it's negative up front, great.
Yeah.
But sometimes we have to proceed with the cath.
Can you guys touch briefly on suprapubic aspiration?
So basically, there are 4 ways of collecting urine. Basically, is the bag, as we mentioned. There's clean catch, there's catheterization, and there's suprapubic. The AAP guidelines of 2011, they made this big emphasis that if it's a child less than 24 months, it should be collected either by catheter or suprapubic. In the audience, I'd be curious how many have ever collected a urine specimen by suprapubic aspiration. It's really academic, and I don't think there's much use for that unless there's tight phimosis, but those can all be solved in different ways. I don't think there's really a place for that, but as Meghan pointed out, catheterized urine, if you want to be sure in an infant, that's really the best way. And it's important in the office when we collect, and I see this in hospitals all the time, where they'll catheterize and the urine will be collected into a little buretrol. It's really important to let the first bit come out because, again, there's periurethral colonization of bacteria. So even the technique with cath has got to be scrutinized.
We don't do suprapubic caths.
Bottom line.
We do not do them.
Yeah.
I asked that when I first started in urology. I was like, so the gold standard says this. Are you guys actually doing this in the clinic? And everyone was like, no, there's no reason to put anybody through that. A catheter is more than sufficient.
Yeah. Okay, great. So we have a patient. They come in with a fever. We decide to get urine, and we get it in a clean way so we can trust it. Tell me a little bit about the testing of the urine.
Okay. Well, I mean, basically, so dipstick is one thing. So leukocyte esterase is kind of a surrogate marker for pyuria, and nitrate's a surrogate marker for bacteriuria. And it would be really rare to have a true UTI in the absence of pyuria. So a lot of people have brought up, maybe, in the interest of starting antibiotics earlier, do we need to always get a culture? That's a big controversy. And adult females, sometimes you can just give them some phosphomycin, some other antibiotic, just based on the UA. So a urine dipstick is definitely useful, but just have to kind of look at the parameters. So another way to look at urine, the dipstick is the urinalysis. So pyuria, they're defined as greater than 5 white blood cells per high power field, and then any bacteria, basically. So as Meghan pointed out, we look at the culture subsequently, and there are different parameters. I like to rely on the AP guidelines, but unfortunately those were retired because of some verbiage that was felt to be controversial in terms of race. So, but most people still use that as kind of the standard. So if we do a culture, if it's a clean catch, actually even clean catch, about 25% could be false positive as well. But clean catch, it should be more than 100,000 colonies of a single uropathogen. And by catheter, even 50,000 or above has a high predictive value. So that's very helpful. Interestingly, now, there's some conversation about PCRs, and I'm not a real big fan of those. PCRs can tell you if there's bacteria present, but we don't know if they're dead or alive, if they're causing infection or they're just coexisting. There are no colony counts. And by definition, a UTI is supposed to have a certain threshold of bacterial colony counts. It's an advantage that they're very quick, but I've had some parents say, oh, can we just do PCR? I know she has a UTI. All the cultures come back negative, but let's do a PCR. And we end up chasing our tails. So that's kind of the newest technique for testing urine, but I'm really not a big fan.
I would agree that the PCR part is very frustrating for me when I get several urine cultures sent to me that are just done with a PCR, because I'm kind of like, well, what's the colony count? How should we treat this? Should we not? And And I think going back to the urinalysis too, something to be aware of when kids are dehydrated, it does not matter their age. When they're dehydrated and that specific gravity is elevated,
good point.
I'm really looking at anything that's like 1.020 or higher. Their urine is concentrated. They're going to have protein. They're going to have some white blood cells. And so when it's concentrated, that messes up your urine dip essentially. And so kind of taking that with a grain of salt, you're typically seeing a positive nitrate and a positive white blood cell on the urine dip. You may or may not have blood that happens on that, but that usually is kind of more indicative of having a UTI. And in our practice, we typically will send for a urinalysis to get more accurate, just more information on that. And the pediatrician realm, I don't think that necessarily you need to send all of them for a urinalysis, but if the dip looks positive, like getting a culture, again, especially if we're talking about more than one UTI, to help us figure out what is actually going on is helpful.
Good point.
Yeah. So the way I look at it, my approach, and you guys can correct me if I'm wrong. So the urine dip, I don't trust 100%, right? I don't think it has a sensitivity that makes me feel comfortable enough. If I want an answer right away in real time, yes, it could be helpful because I can say to my patient, I think you have a UTI and I'm going to send a culture and let's see, but I'm going to start you on antibiotics. I don't always do that because the urinalysis is only a couple hours later. I trust that test a little bit more. But ultimately, if I have a high enough pretest probability that this may be a UTI, I'm sending a culture. And the urinalysis is helpful to me because, again, I can start antibiotics that day. Is that a fair approach?
I think that very much so, that is. I also tell a lot of my families, unless your kiddo has a fever, we don't have to start antibiotics right then. UTIs, they're annoying. They cause annoying symptoms like accidents, pain with peeing, sometimes blood in the urine. But they're not harmful. We're not worried about pyelonephritis typically without that fever and kids feeling really terrible. So I always say, like, look, let's drink a ton of water. Let's have them go pee every 2 hours. And if their symptoms, and also that they're not constipated, and if their symptoms persist after 24 hours, then take them in. Let's check their urine at that point in time. Or if they're already at the pediatrician's office, you can do the urine dip. And if you're not really sure, is it positive? Is it not? It's totally okay to wait on antibiotics. I know that culture takes 2 days to come back, which sometimes as a parent can be hard to wait, but you can tell them, like, this isn't going to make them more sick. Like, we're going to be okay for the next couple of days. Now, if they're seeming very lethargic, you're like, something's just not right with this kiddo, of course, start them in on antibiotics. But I do see a lot of patients who come in that don't actually have a true UTI. And I think we end up in this process of families go to urgent care or wherever, and they're like, they read in the chart of the family, says history of UTIs. They've had 5 in the last year. And they're like, oh, you're having pain with peeing? Okay, here's some antibiotics. And the culture's never sent. They might do a urine dip in the clinic. And those for me are where I'm really trying to navigate away from doing those antibiotics up front. And then I think if, as a provider, if you're giving those antibiotics and we're like, yeah, I think it's probably positive, we're going to send it for culture, following up with those families after the culture comes back, I think is really important to say, like, yes, this was a UTI, continue those antibiotics, or, hey, guess what? Great news. It was negative. Please stop them. Because I think that gets missed sometimes.
We probably should have done this up front, but let's take a moment to define UTI. So pyelonephritis versus cystitis.
Sure. So again, we're looking at that colony count for greater than 100,000 of a single organism on a voided specimen. A catheter is 50,000 or greater, again, of a single specimen. And then that's more of like your cystitis, but pyelonephritis, you typically are febrile with as well. It's extraordinarily unlikely to have pyelonephritis without a positive culture. And I think notoriously somebody ends up at the ER with a fever, they do an ultrasound, and it's kind of like, oh, questionable pyelonephritis on the ultrasound. And then the urine culture comes back and it's totally negative. And I'm like, well, explaining to the family then when they come to see me, like, okay, just kidding. They actually didn't have pyelonephritis and they had no UTI. So if you don't have a UTI, it is almost impossible for them to have pyelonephritis, like extraordinarily unlikely. So it's got to start at the bottom and then work its way up into the kidneys.
But every
That
child
helps.
that goes to the emergency room with the UTI has pyelonephritis.
Okay.
I'm joking.
So I do want to transition into kind of toddlers, but before we do, I think it's really important to call out the frequency of urination in babies and the tests specifically for nitrites.
Yep.
Yeah.
It's important because it's very different from adult medicine. Nitrites are not so reliable in infants because it takes about 4 hours in the bladder for the bacteria to degrade nitrates, dietary nitrates to nitrites. So in infants, they empty their bladder very frequently. And in a lot of children who have bladder bowel dysfunction also empty the bladder frequently. So nitrites are not as quite gold standard as they are in adults in pediatrics. You have to take that with a grain of salt.
Yeah, that's helpful. I mean, backs up, I guess, what I was saying earlier about it not being a super sensitive test, at least for me in the younger ages, which is why I think I lean towards a urinalysis and a culture. All right, let's talk about toddlers.
Mm-hmm.
So toddlers, you have toilet training during that time. Kids are in the bathroom. Little girls are cleaning themselves. Non-specific vulvovaginitis is a common finding. I find the testing of kids as toddlers very nuanced. And I was wondering if you guys could comment on that.
Agreed.
Sure. Yeah, I agree. It is nuanced. There are a lot of different factors that go into it. And one of the biggest ones is when we're checking urine on a toddler, if they're not potty trained, then we go back to kind of what we talked about earlier of collecting those urine samples and how we want to get a good sample. Once they're potty trained, I really prefer the option of, and I tell parents that, you're probably going to get peed on, probably not the first time or the last, but, taking that specimen cup and sticking it underneath them while they're sitting on the toilet and like peeing and trying to catch a midstream sample for them is helpful. But also, like, before we're even checking urine, when you mentioned that vulvovaginitis, like, doing an exam is really important. I see a ton of kiddos who come in for dysuria and the parent is like, they're screaming every time that they pee. And I'm like, can I do an exam? Like, I just want to look on the outside. We don't need to do any type of internal exams, but I go and look and their labia is just like red and angry, or I look at the glands and the foreskin and it looks red and kind of angry. And it's not always like balanitis. It's just that there's essentially like horrible diaper rash happening. And I explain to families too, I'm like, this is like when you have a paper cut and you grab some hand sanitizer and you forget about the paper cut and man, does that thing burn like crazy. Same thing's happening with the urine hitting that raw skin over and over. And like just checking that skin to see what it looks like is usually kind of my first step of like backing up and being like, when is this happening and when are our symptoms happening? And Vaseline is a really good friend to have for those things. And I get a lot of kids that we can get them peeing normally on the toilet without crying and the pain, and all of their symptoms go away with putting on Vaseline before they go pee or a few times throughout the day to really kind of help treat that skin that's just irritated and angry. And I also, on the note of vulvovaginitis, see a lot of families who come in and they're like, we've stopped bubble baths. We only do showers. We've changed our laundry detergent. We use unscented things. And I think all of those are great. I also am a believer, especially as a parent, like kids like baths. I don't love bubble baths, but I tell families, like, if your kid wants to take a bath, like, I'm okay with that. I don't think that that's the reason that they're having a UTI. I don't think that's typically the reason that they're having some vulvovaginitis. I tell families if they want to have one of those awesome bath bombs and live it up, like, great, have them stand up after the bath and shower them, like rinse them down with some just clean water to kind of clean that area a little bit. They can still enjoy those things because I see a lot of families who end up like they're just kind of at their wits end and like trying to figure out what to do. And I still want the kids to enjoy those things and the parents to kind of be able to take a breath and not feel like they're limiting all these things that their kids want to do.
And I think, if you're not using bubbles and those types of things, it can actually be really cleansing for a kid. A sitz bath, right?
Yes.
Just in water twice a day for 15 minutes can be very cleansing and alleviate some of those vulvovaginitis symptoms.
Yes.
And as you said, Vaseline as well.
Yes. Barriers are very helpful.
The other thing I wanted to call out that you said was about midstream. So it's funny. There's a famous doctor here, Dr. Todd, Jim Todd. Hey, Dr. Todd. And one of my favorite people, by the way, but he used to always say there's no such thing as a clean catch. It's just really a dirty catch. But the way to make it cleaner, is to make sure that initial urine stream that may catch some of that skin or vulvar bacteria is cleared away before you get the urine, and you will get peed on, right?
It's pretty much inevitable.
And that's the concerning thing in ERs. I when I ask patients, a lot of them have urine collected in hats, and I don't like those because you can't really collect a good midstream. So that's a little concerning.
And I think too, for those, if you see squamous cells, especially a large amount of them, it's probably not a UTI. That bacteria is because of the squamous cells. Like we need to kind of rethink when we're seeing a positive bacteria, whether it be, on your dip or on the urinalysis. But the squamous cells are the huge one that every time I'm like, oh, there's a large amount. Okay. It was probably skin bacteria that caused all of this.
Yeah. Kevin, wondering, especially at this age, with toddlers and toilet training, if you could touch on bowel bladder dysfunction.
Okay. Well, that's actually about an episode in and of itself.
Okay. Well, maybe we'll have you back.
But so BBD, as we call it used to be dysfunctional elimination syndrome, can present as a myriad of symptoms. And we sometimes call it the great imitator in pediatricians' office, because kids will come in with dysuria, irritative voiding symptoms, feeling of incomplete bladder emptying, abdominal pain, urine infections, etc. So bladder bowel dysfunction has increasingly been recognized as a big risk factor for urinary tract infections. I mean, typically, there have been a lot of studies that have shown this can lead to increased abdominal and bladder pressures, higher post-void residuals, more of these lower urinary tract symptoms, but also urinary tract infections. So it's crucial to take a very good history. Because you can have kids with recurrent infections, incontinence and such, and you can treat the symptoms, but you really have to get to the root of the problem, which is addressing both things. So BBD, basically, if you think about it, the bowel and the bladder come from the same embryologic origins. They share the same innervation, the same musculature, and even some of the same space in the pelvis. So if there's dysfunction in one system, there tends to be dysfunction in the other. And we call it urotherapy. If we talk about prevention of urine infections, I mentioned host factors that we can modify, and BBD is one of the biggest ones. So our mantra is typically time and relaxed voiding, with double voiding to make sure we empty completely, make sure we hydrate well, and make sure we're not constipated. Constipation is another thing that's important, because ask any mom, their child is not constipated. So I like the objectivity of the Bristol stool scale. And we're aiming for Bristol type 4 or 5, 1 or 2 soft bowel movements a day. And one of the important things I point out to parents is a lot of these habits, basically these are habits and physiologic changes that evolve over weeks, months, and years. So once we really start working on them in earnest, it can take weeks and months to kind of reverse the physiology back. And constipation is a good example. I tell parents, if we travel, I know a lot of moms will get constipated. You can take Miralax and they'll have a soft bowel movement the next day, but we've done nothing to change the underlying architecture of constipation. It takes a while to get things back to where they need to be. So consistency is really important in treating bladder bowel dysfunction and preventing UTIs.
Yeah, and I think the interplay of constipation with UTIs, right? Like
Absolutely.
Often a kid who has a UTI, you want to make sure that the bowel is functioning appropriately, because especially anatomically, the bladder can't necessarily behave normally if,
Correct.
The rectum is full of stool.
Absolutely.
Yeah.
Absolutely.
Let's talk a little bit about imaging, because we haven't talked about that yet. So now I know things have changed over time. The things that we think about are ultrasound. We also think about VCUG and the DMSA scan, which is like more of a long-term thing. But I was wondering if you guys could touch on it. Yeah.
So basically for decades, UTIs were considered the harbingers of underlying anatomic, physiologic abnormalities. And the biggest concern, as you point out, would be vesicular reflux. So it was pretty much standard care on every child who had a first UTI of any sort to get a renal bladder ultrasound and a voiding cystourethrogram. when you do VCUGs, about 30% of kids on average are found to have reflux. But what do we do with that information? And if we do a DMS renal scan, about 10 to 20% were found to have quote unquote scars. As we look back now, it seems that a lot of what we thought were scars, reflux nephropathy, actually was just developmental dysplasia of the kidney. But that's a whole another topic to go into. But because of that, kids were immediately placed on antibiotic prophylaxis for years. We would repeat studies annually. And if children didn't outgrow reflux by about 5, we would usually recommend surgery. So we didn't really have any randomized control studies that backed up the efficacy of antibiotic prophylaxis or even what we were doing. There's studies showing even surgery is not necessarily changing outcomes any differently from prophylaxis and preventing UTIs. So in the last 10 to 15 years, there's been a real change in focus on not being as aggressive in our testing and our management and really trying to be judicious in our use of these interventions, our resources, and potentially harmful testing and such without really changing outcomes at all. So there's been a real paradigm shift in the way that we've been approaching urinary tract infections.
And I think touching on the VCUG when we're checking for reflux, as a group, like we realize that this is impactful for kids and their parents when they have to go through getting a catheter placed and have that test done. And as Kevin was mentioning, we used to do it all the time. And now we're really trying to be really judicious about when we order that. Typically, and everybody practices a little bit differently, but like for myself, I want kids to have 2 febrile urinary tract infections that are confirmed on culture before I'm willing to kind of put them through a VCUG. Some exceptions, depending on how the parent feels and if the kid's really little and they were really sick and in the hospital, like it's traumatizing from that perspective too. But when you reach that 2 to 4-year-old age, it's hard to do a VCUG on them. Like, anybody who's been around a 4-year-old, you can ask them to do anything. And if they're not willing to do it, they're not like, good luck. But then we're going to hold them down and put a catheter in. Like that can be traumatizing. And so there's benefit in ordering it when we really need it. And then there's also a lot of benefit in working up for other reasons. And so I really encourage people, like if you think that somebody might have reflux and you want a VCUG, like that's what we're here for, is to help order those and order them in a fashion that we're used to looking at. We get outside orders sometimes where an ultrasound VCUG will be ordered and done instead of a fluoroscopic VCUG. And we typically order a fluoroscopic one. And that's also what the surgeons are used to looking at as well. And so, people have preferences, but if you're on the outside and you're ordering something to then send to us, but it's not really what we want, we're not going to put somebody back through the test very likely unless we have a high concern, but we're trying to work with everybody to get them what they need. And I would say the same thing for the DSMA scans. Like if you're remotely thinking you should order it, they should probably be seeing urology for that. Good point. So that we can help figure out what's going on. Because also interpreting those results are very nuanced. And there's not just this straightforward, like, yes, this means surgery and no, this doesn't mean surgery. Like they are very nuanced. And so we want to help with those things.
That's very helpful to know. Were you going to say something?
Well, I was just to say, the AUA guidelines with reflux, basically, one of the first recommendations is to look to see if there's any bladder bowel dysfunction. And if there is, that must be addressed before even thinking about surgical intervention. So there's research that showed that, kids who have BBD have higher likelihood of having breakthrough infections while on prophylaxis, are less likely to spontaneously outgrow reflux, and have a higher risk of forming scars. So, again, we're circling back to, why are we doing all this testing, and really what is the outcome of it, as Meghan really well pointed out.
So we've been focused on the little kids. And I know there's sort of a gap during school age where UTIs don't happen very often unless they have recurrent UTIs or something. But what about adolescents? Adolescent females especially can have recurrent UTIs.
They absolutely can. I would say majority of the patients that I see aren't actually having recurrent UTIs. They have negative cultures. They have poor voiding habits. They pee once at school or 0. They drink no water. And so it kind of, again, relates back to that bowel bladder dysfunction that we've been talking about. And so reinforcing with them like posture, how you sit on the toilet, feet flat on the floor, legs apart, elbows at your knees. And so you're leaning forward really helps with emptying, taking the time to pee so that you're taking, a big deep breath, allowing the bladder to actually empty because you've waited 6 hours to go to the bathroom and the bladder's very full. Those tend to work really well and treat a large majority of the symptoms for the patients that I'm seeing in adolescence that come to see me with the diagnosis of a recurrent UTI. But when I'm kind of digging into the underlying reasoning for it, it's more so that they have poor bowel bladder habits.
Kevin, we don't have time to go into great detail about treatment. Could you briefly just touch on treatment for UTIs?
Well, generally, it's important to really look at if there's a local antibiogram to know what resistant rates are in the community. But, obviously following up on cultures and make sure that we're looking at the ID and sensitivities. And happily, these days, we're seeing more and more that we can treat children, even if they're febrile, with IV antibiotics. And when they're clinically well, switch them over to oral antibiotics. There was a good Cochrane study on that. There is one new antibiotic on the horizon right now, which is called Blue Jepa, which I think is gepotidacin, which has been approved by the FDA in 2025 for the treatment of girls 12 years of age and older with uncomplicated UTIs. But it does have potential for treating some resistant organisms too.
So we covered a lot of material here. What a great discussion. So interesting for me and hopefully for our listeners as well. And I just want to call out that there are recommendations, guidelines online for people. I'm very lucky because I have you here, but not everybody does, right? And some people are working in places that are more remote and have to handle these things on their own. But anyway, I really appreciate you guys coming and talking. I really appreciate the conversation and all that you do.
What a
Thank
pleasure.
you.
Thanks
Thank you
for
so much.
inviting us.